Hi, and thank you for joining us right here at Prostate Cancer Live. I'm joined by our medical director, Dr. Rich Bevan-Thomas from USMD out of Arlington, Texas. Doc RBT, how are you?
I'm good, Todd. What's happening, man? Good from
Good to
Dallas, Texas.
from
Ebola
Dallas,
land.
Ebola land.
Actually, it's
Um,
good. We're all good. It's just a couple small little segment right there, but not in Arlington.
Incidentally, just out of curiosity, how far are you from the hotspots of Ebola?
So we're about 20 miles, give or take. I mean, and the issue is, I think it might be a bit stretched to call it a hotspot, as a true definition. We
Right.
actually have, the original patient who died, and then the nurse, the one nurse, and then they just flew the other one out. So it's in one hospital, but that's a good 20 miles away. So
Cool.
it's good
Well,
news.
let's keep it there.
Yeah,
And
exactly.
all right, so today we're going to be talking about robotic surgery and for prostate cancer patients. We're also going to discuss what to expect if you're a patient and your physician is recommending robotic surgery. And I think it's a wonderful topic, and really, who better than RBT to talk about this with us? Doc, what is robotic surgery for prostate cancer patients?
So, Todd, we were talking about this to begin with. I think the first thing that we try to do, I've been actually doing robotic surgery actually since 2002, 2001, 2002. And the first thing I try to explain to people is what is the robot, so they can understand it's not just sort of a R2D2 where you hit a button that says prostate remove, and then you go out in the corner and have a smoke or a martini, and then it just takes the prostate out for you. So I think it's important to understand that. And we've got a couple pictures here. So right there, let's leave it right there for a second. That's actually those are the robotic arms, and those actually go right alongside. And what they do is they actually attach to, it's laparoscopic surgery, but it's a way that we do advanced laparoscopic surgery. So normally, if you see those little arms attached to those instruments there, and those are what we call the endo-wrist instruments, we make little keyhole incisions, and these are the instruments that actually go through those keyhole incisions. And these arms here are actually controlled and away by the console. Now that's the next picture, which is perfect. Nice segue. And
Thank you.
that's actually all right, it's like it was rehearsed, right? So that's the console where we sit as a surgeon. And as we move our hands, you can see that lady's hands, kind of stretched out right there. And then you can see that's little joysticks that we actually hold. And as we're moving those around, it's subsequently moving the instruments actually that are attached to the on the patient side. And again, there it is right there. That's there you've got our integration with the entire robot. And again, that's the on the patient side, patient console wise, is looking right at that. So the point on this is that it's not where the robot. And again, there's great things you can go under USMD, prostatecancer.com, 1-888-prostatecancer.com. We kind of explain this a little bit too. But what I think the important thing is that it's not as easy as you just hit a button and it takes the prostate out, takes the kidney out, does all the different procedures that we do. So it's a way in which we control instruments to do laparoscopic surgery.
And these instruments can get into smaller places than the human hand can with traditional devices, and make non-conventional angles and turns, right?
Sure. So what I tell people, laparoscopic surgery, so we sort of are aware of arthroscopic surgery, and arthroscopic surgery is actually where we take little cameras and we actually put them into the joints. So orthopedic surgeons do a lot of that. So laparoscopic surgery is actually when we look inside the abdomen with a scope, right? And when you do laparoscopic surgery, normally it's like working with little chopsticks. And we could do pretty good laparoscopic surgery from that, but the problem is that at the end of those chopsticks, you're sort of moving things around, and as you've been to trying to eat sushi and eating specific, whether it's going to be noodles and things like that, like they can be kind of tough to use. It's definitely a skill set. But at the end of these little chopsticks, we have the ability to actually move at the bottom part of those things, so it's almost like having little hands inside there. So it makes our ability to do laparoscopic surgery better, and as a result, we're more efficient doing those procedures, and we also are more precise.
Now, it seems to me that, and I've watched a couple of laparoscopic procedures done before and been in the OR, it seems like because the devices are smaller and your vision is placed, inside, that the recovery is actually quicker from robotic surgery also than a traditional surgery. Is that accurate?
So yes. So again, you have to think about it's laparoscopic and robotic. Again, let's kind of go to that definition again. Is that laparoscopic? Robotic is just a way in which we do laparoscopic surgery. I said that for you, right? So it's inside joke there. So
can I just tell them, because it made it kind of fun. All right, so we have a little inside joke here, and Doc RBT loves to say the word again. So he's getting deducted 5 points from his season total for each one. And if you go back and reel this thing back to the last sentence, he used again 3 times in like less than a 10-second time frame. So thank you for cracking me up.
So Todd used to work as a 3rd grade English teacher. So just pardon all of his little challenging idiosyncrasies that he has. So back to our point now. So when we actually are doing laparoscopic surgery, robotic surgery, advanced laparoscopic surgery, that's the difference. That in itself is basically the same thing. That patient's going to recover quicker because we're doing laparoscopic surgery. Is that patient going to do better than the open surgery? And that goes to your point, which is in the old days, and I really do mean the old days now, 5 plus, 10 plus years ago, the standard of care really was doing open surgery. So we'd make a bigger incision. We'd have to put our hands in there because we didn't have the ability to we were doing laparoscopic surgery. It was a challenge. Robots was actually coming more and more up into the forefront. So by doing that, you're right. Laparoscopic, i.e. robotic surgery, has made it easier for the patient to recover quicker. Normally, these patients will go home the next day, and there's a whole host of other benefits that they can actually get from these surgeries.
Now, for those of you who are watching, please keep in mind that I'll be working to see if there's a question submitted. So feel free, if you've got a question that you want to ask about robotic surgery and prostate cancer, and it fits within the flow or the context of the conversation, and it's not case specific, meaning it's a general question, then by all means post it, and if it works, I'll bring it up and then Doc RBT will answer it for you. Now, Doc, I've worn these 3D glasses, and do you? I mean, it's in 3D, right? Well, the way you do it.
Right. So we don't wear 3D glasses when we do it, and that's a bit of a problem because the problem when you're wearing 3D glasses is you're taking a 2-dimension or 2D image and you're trying to convert it, and that may work for about maybe 20 minutes or so, and then what happens is your brain starts figuring out pretty quick and you start getting a headache. So what happens is the camera itself for the Da Vinci actually has two separate cameras in it. So you literally it's like those 2 little lenses are going all the way up into each individual eye. So it's true 3-dimension. So that way you don't have to wear, you're not wearing any eyes or lenses or anything along those lines. You're literally looking, and again, that console that we looked earlier, you put your head directly in and it's true 3D. Because, in the old days, again, I've been doing this since 2002, there was a competing company that actually was, and that was called the Zeus. And the Zeus, I was helping them out a couple of things, and one of the things was actually trying to take that 2-dimension. We would wear those glasses, and it would convert over into 3D, which sounded like a great idea, but, bottom line was that in about 20 or 30 minutes, you'd start getting a headache because it's far more difficult for your brain to process that. So if you have true 3D the whole time, it's a much better way to go, and your eyes will tolerate it better.
And the reason I ask is when I looked at we were taking those photos at one of the conferences that Prostate Cancer Live was at. Photos I showed a few moments ago, I put on and looked inside of the 3D hood, and it was pretty remarkable, the depths and distance between the different layers inside the body.
Yeah, so, and that goes to when we're looking at 3D, the real advantage of 3D is that for surgeons that aren't used to doing pure laparoscopic surgery, which is 2-dimension, it helps you out with the foreground and the background. It certainly helps out knowing where you are in each step. And so it's an easier surgery to learn. It's also a little bit easier on your eyes because, again, you're looking at it in true 3D, and it makes you more efficient. So bottom line is that, again, it's helpful. Guys can learn it easier, but those of us who have actually been doing it for years, it definitely makes us more efficient.
All right, can we talk about outcomes? Naturally, outcomes has got to be the most important question that a patient's going to ask you when considering robotic surgery for their prostate cancer. What should patients know?
So the first question we have with outcomes, when we first were starting to look at robotic and laparoscopic surgery in the early 2000s, the real question was, is it any better than open surgery? And that sort of continued to be debated back and forth. And we had sort of the open surgeons versus the laparoscopic and robotic guys, and this sort of became, a little bit of a debate back and forth. And what's happened is that there's clearly no debate on this in the sense that, patients will actually have less discomfort with doing it laparoscopic and robotic. And I think that's pretty well understood. Even if you make a small incision, those patients certainly have a higher risk of having more discomfort from that. There's different ways to minimize that. And so what happened was that as time progressed, robotic, and certainly for the field of prostate cancer and prostatectomies, actually became more of the standard of care. And now, in 2014 and 2013, it's over 85% of all prostate cancer surgeries, prostatectomies, i.e., are actually done robotically. So it's really become, the new standard of care in which how we do this.
Beautiful. Okay, I love it. What are the fears that patients express when you talk to them about robotic surgery? What's common?
So I think that just like in the open surgery, the big things that we worry about for that is, number one is they worry about the incontinence risk. In other words, are they going to be losing urine when they cough or sneeze afterwards? And the second thing that they worry about is erectile dysfunction. And why is that? Well, because when we're taking the prostate out, that prostate is actually between the urethra and the bladder, right? So we gotta take this out. I sort of compare it to a donut, and you urinate right through the middle of the donut. So we take out the donut, and then we put the urine channel back to the bladder again together. So by doing that, what happens is that because you're urinating right through the middle of it, we want to try to minimize any damage to the surrounding structures so that it'll minimize the issue with incontinence afterwards. And the definition of incontinence is leaking, whether it be stress incontinence when you cough or sneeze or you get out of a chair, and that is a certain risk. And there's a lot of things that we're doing now that has really evolved over the last 10 years or so, give or take, that's actually minimized that risk for incontinence. In most patients, we can actually, if we're doing it, I would say, patients who actually don't have, other, issues associated with it, whether it's going to be, a previous, they've had previous surgeries on their prostate, where they've had radiation. Most patients will actually regain their continence, their urinary function, actually pretty quickly. And again, there's other factors that involve in there. It's not 100%, but there's always the risk. And I think it's important to really chat with your surgeon to make sure that they've got the experience, to make sure that they've done, a good, several hundred of these things. So they've been through the mill a little bit. And I think it's important to really have that experience. So that's the first thing we worry about is incontinence. That's everybody wants to make sure, and they say, am I going to be leaking my pants, for 6 months, a year, 2 years, or for the rest of my life? And the answer to that is almost invariably no. There is that risk, and that risk is low. And again, routinely, that risk should be routinely less than about 10%. Again, you really just have to talk to your surgeon about, the different factors that go into that. And the second thing is erectile function. Are they going to be able to get erections afterwards? And these are the two big things. So the reason why we worry about erections is because the prostate, again, think about that golf ball, and alongside that golf ball are those nerves that actually are responsible for they generate an impulse that goes alongside the prostate, and then it goes directly down to the penis. And what happens is those release a chemical. That chemical causes blood flow to actually go into the penis, and that's how the man gets the erection, right? So if those nerves are damaged, that impulse that actually goes down and releases that chemical will get affected, and subsequently those patients unfortunately can't get erections. So we try to spare those nerves. But there's a lot of things that go into preserving the erectile function. The first thing we want to ask those patients is, how good are your erections going into surgery? Because I think people have to have realistic expectations. If men are not able to get erections good enough for intercourse prior to surgery, unfortunately, we haven't created the bionic man yet, or at least the bionic pelvis. So, we can't make those erections any better after surgery than they were prior to surgery. So it's very, very important. We do what's called a SHIM score, which is a sexual health of inventory for men. And what that lets us know is it lets us know how that man is doing. It's a scale of 25 up to 1 to 25, and it lets our 0 rather, and it lets us know how those man's erections are doing, and it lets us know how he progresses. As a whole, again, assuming that we can spare, those nerves, sometimes we just spare one side of the nerve, sometimes we can spare both sides, sometimes we have to do limited sparing. So a lot of that you just have to discuss with your surgeon about how many or how much of those nerves you can spare. It's not as easy as just seeing a big fat white nerve and you just peel it off and you're like, woo, and everybody's giving high fives and go, yeah, I spared the nerves, because they're what we call a plexus. And that plexus basically it's like a bunch of little hairs that actually run alongside the prostate, and you gently have to peel that off along with the blood supply that supply those nerves, so those nerves can actually start functioning again. So those are the two main questions. Again, a majority of men, again, if we're going to spare the nerves, and again, we're not doing extensive surgery, I said that for you, so we can actually get their urination back on track as well as the erections back on track pretty quick.
All right, one question we did get submitted is about recovery time from a robotic surgery for prostate cancer. What is that typically?
So most patients will go home the next day after the procedure. It's rare that we keep them longer than a day. The catheter, what we do at USMD is most of my partners and I actually do what's called a catheter-less. So they'll go home with a catheter in the lower abdomen as opposed to a catheter in the penis. And I think there's a little bit of debate over that, but I think it certainly is more comfortable for the patient, and we've actually seen good results with that. And we'll usually take that catheter out within a week, whether it's going to be 5 or 7 days afterwards, but it's somewhere within that time period. Most patients then are ability to go back to work within the first 10 days to 2 weeks. So a lot of it depends on what they do. So if you're an accountant, I've had preachers and pastors that I've done surgeries on them on Thursdays and Fridays, and they've gone and they've actually given sermons on Sundays. I usually tell people to really try to take it easy, take advantage of this time, and I tell people at least 10 days to 2 weeks before we get you back to work. Now that's a little bit of an exception. So if we do patients who do a lot of manual labor or lifting heavy things, we do want them to delay that if at all possible. And the problem is we worry about not necessarily they're going to dislodge something, if they're trying to move a refrigerator, but we do worry about them potentially developing a hernia where we make those little keyhole incisions. And so for those patients, it's usually anywhere between 4 to 6 weeks, and then again slowly get back into the rhythm for the most part.
4 to 6 weeks is a long time for people, and that's just for people who do manual labor. Is that right?
That's right. So most of my patients will go back to work within the first couple weeks, and if they at about 2 weeks and a day, usually their wives will call up and say, hey, can I get my husband back to work because he's driving me bananas? And they will get him back to work because they want to get back to work. They're actually feeling pretty good, and most patients actually feel pretty good with that. So it's really just the manual act or the manual labor, and I think the lifting heavy objects. Anything I tell patients, for the first 4 to 6 weeks, certainly for the first month, I just don't want them lifting anything heavy. And I think if they will abide to that, again, I've had guys, as early as 3 or 4 days. I think it's a good idea. I usually tell people our goal is to get them back within the first couple weeks after surgery.
All right. So with I'm sure people ask you this question a lot, but I'm curious about it. Are we winning the fight against prostate cancer? Are we making significant progress? What's kind of the lay of the land on that?
So I think we are. I think that one of the challenges that we have is with prostate cancer is, and we've seen this over the last several decades. And I don't want this to get into a whole screening debate, but what we do know is that we know that if we find patients who we can catch early enough in the disease process, we can actually cure them much better now than we can 20 or 30 years ago. And we know that from a number of different studies. We know the mortality rate has actually decreased somewhere in the ballpark of around 30 to 40%, and that's since the advent of the PSA. So the goal with prostate cancer is to make sure that if we find those cancers and we find them early enough before they get outside the prostate, we can actually cure a fair number of those patients. So the big challenge, of course, that we're seeing now is twofold. We don't want to overtreat prostate cancer, so those guys with really low-grade disease, and we've talked about our active surveillance, but we also don't want to undertreat prostate cancer, because if we undertreat those patients and the cancer gets outside of the prostate, unfortunately we're going to start seeing a recurrence on those. So are we winning the fight? I think we're definitely getting there. I think that over the last 30 years, I think we've seen significant improvements. I really think that where we're going to be headed in the future is we're going to be concentrating primarily on these high-grade diseases. And the problem with the high grades, and we're talking about the 8, 9s, and 10s, if we can get those patients early enough, if we can find those, and we can find those patients and actually treat them at the earliest phases, so they're not like high volume of glycinate where it's already gotten outside the prostate. Those are the patients that I think we can actually do the best work on, and certainly help them get cured. And I think that's where we're headed. You know, we'll do a follow-up one in the near future here about MRIs and how we're actually finding prostate cancer in the future. But I think we're making headway. It's unfortunately it continues to you know, we still have the death rate for prostate cancer continues to be much higher than I'd like to see, and it's upwards of 28,000 men a year.
Yeah, that's way too high. Well, Doc, thank you very much for spending time with us tonight. This is a topic that I'm sure comes up all the time. I know it happens with our audience at Prostate Cancer Live, and we're grateful for your time. On behalf of Doc Rich Bevan-Thomas out of USMD in Arlington, Texas, and our good friends at Prostate Cancer Live in Scottsdale, Arizona, we want to wish you all a very healthy and happy week. We look forward to answering your questions in the coming Hangouts on air and in videos. Feel free, do not stop submitting. We read them all. We're now over 116,000 followers just here on Google Plus alone, and growing across social media. So, Doc, thank you so much for your time to helping us lift up the understanding of prostate cancer.
Thanks, Todd. And you said again, I would like to remind you. So
yeah. No doubt. I'm sure I did. We'll look forward to talking with all of you real soon.
All right, bye, guys.
We're almost clear. It hasn't said we're not clear.